Our next speaker is Dr. Joshi, and let me tell you what, he has more letters behind his name than any other doctor that I know. And to me, like, what the heck does that mean, and why do I care? Well, let me tell you, I learned the hard way why that matters and that I should care. It is really important that you let the pain doctors handle your pain. Dr. Joshi is an anesthesiologist and interventional spine and pain management physician at National Pain Centers in Vernon Hills and Hoffman Estates, Illinois. If you're not from here and you don't know where that is, it's like 10 minutes up the road. It's likely that you do know the term central sensitization, and not in a good way. If you don't, you surely feel it. Dr. Joshi is going to talk to us about central sensitization and ketamine. Please welcome my doctor, Dr. Joshi.
So a couple things we want to talk about today. Number one, we want to define pain and define some definitions for you. Number two, by the way, I have nothing to disclose here. Unfortunately, nobody paid me to be here today. So by the way, we have a tip jar outside if you want to. No one paid me, and actually it's really an honor to be here today. And Gracie, thank you again for having me here, for inviting me here. One of the reasons I like to present or lecture is because I really truly feel that we have sort of this problem in medicine today where it's become incredibly corporate. It's become a business. Everything is about how do we make more money, and nothing's about how do we do things correctly. It's not about how do we educate correctly, how do we empower patients so they can make the right decisions for their body. It's about how can we continue to increase revenue so the guys in the ivory tower are happy with our performance. I don't think I'm saying anything that you guys probably already don't know. So that's one of the reasons I'm here today is, hey, how can we educate the population? How can we let them know about what some of the real science is so hopefully they can make good decisions for themselves and empower themselves in terms of what the right type of management is. So learning objectives today. Number one, we're going to talk about definitions in the pain management world. I'm going to take this off, actually. All right. Number two, I want to talk about the various types of pain. So there's no such thing as just one type of pain. It's not just like, oh, I have pain. It's not the case. That's like saying I'm alive. That doesn't mean anything. It's just like saying I'm a human being. That's wonderful, but there's different types of human beings. We need to identify what type of human being you are. We need to identify what culture you have, what socioeconomic status you have, what health status you have. All those things play a role in who you are as a human being, which is why it's so important, by the way, if you do see a physician, that they take a look at you as a human being. They take a look at who you are and try to understand who you are. Try to understand the experiences that you've had, because they all shape who you are, and they shape the way that your body interprets pain. So if you fundamentally don't understand the person in front of you, there's no way that you can actually adequately treat that person. Period. I'll repeat that. Okay? If the physician doesn't adequately understand the patient that's in front of them, there is no way that they can adequately treat you correctly. It's kind of like a car. Okay? There's more than one type of car. Everyone agree? There's more than one type of car. You can't just say, I fix cars. If you don't know that model, if you don't know that make, you cannot fix that car correctly. If you've got an expensive Lamborghini and you go to your, local whatever, I won't name names. I don't want to insult any, car company. I was going to say Yugo because, remember the Yugos? Those little cheap little cars? Yeah, those are a long time ago. Maybe we could use them because they're not in business, so they won't come after me. So you can't take a Lamborghini to a Yugo dealership. Those guys aren't going to know how to fix it, right? They need to fundamentally understand that car, that engine, what has it been through, so they can understand how to fix that thing correctly. So it's the same thing with physicians, okay? No different. So if your physician spends 2 minutes with you, I'm sorry, I really don't think that they're going to do a great job taking care of you. So we need to understand the different types of pain. If we don't understand different types of pain, we can't treat them adequately. We need to discuss what central sensitization is. Central sensitization is a concept that is more than just a concept. It's real, it happens, it's a type of pain. We need to understand why it happens so we can understand how to treat it better. By the end of today's discussion, I promise you, you will actually have been exposed to more information and probably have more knowledge about central sensitization than at least 95% of physicians out there, which is wonderful but sad at the same time, right? But again, it's about empowerment, right? It's about knowing what's going on so you can communicate that adequately to a physician. Talk about ketamine both as a molecule as well as a treatment option for central sensitization. Talk about ketamine infusions, which is the delivery of a certain molecule in a specific way whereby we are reversing some of the pathologic processes that occur with central sensitization and some of the diseases that are encompassed by central sensitization. And finally, we'll discuss barriers to treatment. We'll discuss all this wonderful information, and you'll probably be like, wow, this is great. Why aren't more physicians, why aren't more hospitals, why aren't more people offering these options? We'll talk about that as well. So what's the definition of pain? Well, everyone has heard of the International Association for the Study of Pain. Have you guys heard of that? They're kind of like the sort of body that sort of puts out definitions, and we live by those definitions. And their definition of pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage, or described in such terms of that damage. Now, putting that into simple English, it basically means something that bothers you. It could be real, it could be not real, but it could be emotional, it could be sensory. So that includes things like depression. It includes things like anxiety. It also includes things like, broken bones, okay? There's a couple other definitions of pain. I think these are actually what are more widely used. What's the definition of pain? You go to the ER and you say, I got pain. They're going to be like, oh, I don't understand what that is. That's French bread, isn't it? No, that's not the definition of pain that we're using. But I think you've all run into that situation where a lot of physicians who think that, we got this other chronic pain patient coming in, and they look at you like you've got 3 heads and you're a drug addict. Right? So they probably say, well, pain, that just means French bread. I don't have any other definition for pain. And then you've got the other definition of pain, painful, and this is from the Urban Dictionary. See reality TV. Survivor is painful to watch when used in a sentence. All right. Other definitions that the IASP has, they have definition for allodynia. Has everyone heard of allodynia before? Okay. So allodynia, the real definition, the official definition is pain due to a stimulus that does not normally provoke pain. For example, if you're walking outside and the wind blows on your skin, and you say, oh my God, that is the worst thing I've ever felt in my life, that is allodynia. That is obviously not a normal sensation. Dysesthesia, an unpleasant abnormal sensation, whether spontaneous or evoked. Hyperalgesia, increased pain from a stimulus that normally provokes a little bit of pain. For example, if someone presses on your skin, shouldn't cause too much pain. Maybe, they press on your skin with maybe 5 pounds of pressure. Like, not the most comfortable thing in the world. But if that pain causes you the worst pain you've ever felt, that's called hyperalgesia. Hyperesthesia is increased sensitivity to a stimulation. Hyperpathia, a painful syndrome characterized by abnormally painful reaction to a stimulus, especially repetitive stimulus. Neuralgia, I think you guys have all heard of that definition, or that word at least, is pain in the distribution of specific nerves. Okay, so when I say, hey, you've got neuralgia, that typically refers to the fact that you just have some pain in a certain distribution. Okay, neuritis, an inflammation of nerves. That means that you've got some inflammation. So, for example, people have said, you've all heard the definition, sciatic pain. Sciatic pain, you get the shooter that goes down your leg. That's sciatic pain. What is sciatic pain? It's a type of neuritis. It's an inflamed nerve. Okay. Neuropathic pain. Neuropathic pain is pain that's caused by a lesion or a disease of the somatosensory nervous system. So there's a lot of types of neuropathic pain. We break those down into 2. There's central neuropathic pain and peripheral neuropathic pain. Central neuropathic pain is pain caused by a lesion or a disease in the central nervous system. The central nervous system means the brain and the spinal cord. The peripheral nervous system is pretty much everything else. So we want to make sure that we split those up into 2, central and peripheral. So central is brain, spinal cord, peripheral is everything else. Neuropathy, disturbance of function or pathologic change in a nerve, okay? So some type of neuropathy is basically a disease of a nerve. Nociceptive pain, pain that arises from actual or threatened damage to non-neural tissue. So, if you've got a problem with your stomach, if you've got a problem with a bone, if you've got a problem with some muscle, that's nociceptive pain. Okay, very different than neuropathic pain refers to pain because of an injury to a nerve. Sensitization is increased responsiveness of nociceptive neurons to their normal input. Central sensitization is obviously that definition in the central nervous system. So again, increased responsiveness of nociceptive neurons to their normal input in the central nervous system. Peripheral sensitization is referring to that same concept in the peripheral nervous system. So that's where the definition of central sensitization comes from. Okay, so now that we've kind of broken it down, you have an idea of how these words, because these are all words at the end of the day. Words are nothing more, I think I was talking to you earlier today, and words are nothing more than just some random language with a bunch of letters and characters, and we put those letters and characters to describe a scientific process, an objective scientific process. And that scientific process is nothing more than atoms and molecules having chemical reactions, and in some cases those chemical reactions can go a little haywire. And when that happens, we try to describe it with words, okay? So we try to get a better understanding of what's going on. But ultimately, and we'll talk about some of the mechanisms, ultimately what's really going on is the universal language of science and math is what's going on. And we want to try to understand what that is so we can better treat patients and have better outcomes. So common causes of pain, I think you all know that the most common cause of pain, the most common reason that patients will see a physician is lower back pain. Okay, lower back pain and arthritis pain account for half of all muscular disease diagnoses. On top of that, when you look at just lower back pain, if you look at the patients who are under 45 years old, the leading cause of disability in those patients is lower back pain. That's a major, major problem. You know, chronic pain costs America $635 billion a year. $635 billion a year. A lot of that is from things like disability. So if we can't keep our population healthy, it costs all of us. Our taxes go up, our healthcare costs go up, not to mention quality of life. Our friends, our family, you know, they're not happy, and that's not good. There's no price to that, right? That's priceless. But that's one of the leading causes of disability under the age of 45. 26 million adults per year experience frequent back pain. About 15% of Americans who experience back pain, it lasts for greater than 2 weeks. And as we all know, if those things aren't taken care of quickly, they'll progress to something called chronic pain, which becomes a totally different beast and a different way of handling that. Arthritis and chronic joint problems affect about 70 million individuals. 18 million are osteoarthritis, about 2 million are rheumatoid arthritis. So here's the different types of pain. And we kind of briefly touched on it when we looked at the definitions. We have nociceptive pain. Those things can be things like, you know, burns, cuts, you know, bones broken, things like that. Neuropathic pain, that's nerve damage. Those kind of diseases are like herpes zoster or diabetic peripheral neuropathy, sciatic pain, radiculopathy. Those are all definition of neuropathic pain. Inflammatory pain, arthritis. Okay, that's the most common cause of a neuropathic pain, or inflammatory pain, excuse me. Inflammatory pain can also refer to autoimmune disorders where you have inflammation. You know, one of the things that people don't think of typically with inflammatory pain are skin disorders like psoriasis and psoriatic lesions, but those are all inflammatory conditions. And then finally, central pain amplification, central sensitization. Some of those diseases are things like fibromyalgia, CRPS, or RSD. So we have to understand what category that patient's in. If we don't understand what category that patient's in, then we can't treat them correctly. You know, typically we just showed you now 4 different definitions of pain, right? 4 different types of pain. I tell you right now, you know more than most physicians out there. Literally, by just knowing that. Because what happens when most physicians think pain is just someone complaining. No, it's actually those 4 different categories. And if you don't put them in those 4 different categories, there's no way you can go down the subcategories and go down the right pathways to treat the patient correctly. So again, other categories of pain. Now, if you've defined the types of pain, we got to now split up into categories of pain. So there's acute, chronic, and palliative. Acute is basically short-term, typically 3 months or less. Chronic is typically 3 to 6 months or more, and palliative is essentially just we're trying to keep the patient happy, we're trying to keep the patient feeling okay, and they have a disease process that's really not going to improve or get better. So who provides these services? Well, we've just opened up a whole new ball of wax. Who provides these services? What is a pain doctor? Anyone know what a pain doctor is? Give me just one person. Just give me a definition. What in the world is a pain doctor? So it's safe to assume that pretty much everyone here either has chronic pain or has a family member with chronic pain. Everyone here has been to a physician or has a family member who's been to a physician who claims that they're a pain doctor. What in the world is a pain doctor? Okay. So yeah, right. So someone who should. Right, so someone who should be helping you find out where your pain is and maybe help you get better. True. So now we look at the people who provide those services, right? It's enormous. You've got anesthesiologists, emergency medicine, general surgery, interventional pain management, typically through anesthesiology, but sometimes through some other specialties. You've got oncology, neurology, neurosurgery, orthopedic physiatry, psychiatry, primary care, internal medicine, radiology, rheumatology, and trauma surgery. And I've probably missed a few. And that's just in the physician world. Now, outside the physician world, we have chiropractors, CRNAs, nurse practitioners, physician assistants, physical therapists, massage therapists, acupuncture, holistic or homeopathic doctors, DME providers, hospice and home health providers. And if I've missed any, I apologize. I feel like I'm here at the Oscars or something trying to think, you know. And there's like Gracie there with the time card. You're out of time. Hurry up. I'd like to thank my family. We've got so many people providing pain management services, right? How do we keep them straight? We have no way of keeping them straight. So what is a pain doctor? It goes back to the beginning definition. Now, if I said, what's a cardiologist? You'd be like, oh my God, I know exactly what that is. It's a physician who's done internal medicine and a cardiology fellowship. Done. Period. End of story. That's it. There's no debate on that, right? I ask you, what's a pain doctor? And everyone here has been or has a family member who's been to a pain doctor. Well, here's the problem, right? We're missing the big picture here. What we have is we have multiple specialties that are taught their little narrow sliver in the world of where they fall, in their specialty. So you have the psychiatrist who looks at that, the elephant, here, and he sees depression. You have the otolaryngologist who looks and he sees TMJ. Then you've got the neurologist who sees a chronic headache, and you've got the rheumatologist who sees fibromyalgia, and then of course refers it out because they say, oh, we don't treat fibromyalgia. Then you've got the cardiologist who sees a non-cardiac chest pain. You've got the gynecologist who sees PMS. And you've got the gastroenterologist who sees irritable bowel syndrome. Does this even remotely sound familiar to at least a few of you? We're missing the big picture here, right? And this is kind of the problem, I think, that we see in medicine. And it's only going to get worse because at the end of the day, for the gastroenterologist to look beyond his scope of training and to spend that much time invested in you and quite frankly not get paid anymore doesn't make any financial sense. And his administrator who, or his boss or even if he owns his own practice, he's going to look at the bottom line and say, hey, listen, I can't do this because I'm losing money. I'm not making money. I'm going to lose my job. So how do we go beyond that? Well, that's not the focus of this discussion. Thank God, because I'm not sure I have an answer to that one. But that is one of the problems that we see with pain management. Is you've got everyone under the sun trying to help, trying to figure out what's going on, and hardly any of them have formal training. So they're spinning their wheels, but not getting anywhere. So typically, looking at just an interventional pain specialist, typically it's an anesthesiologist who's done a fellowship in interventional pain management. Typically they can perform over 100 different type of procedures. You can do a variety of different things, a lot more than just an epidural steroid injection. Just in the lumbar spine, there are 20 different ways to do an epidural steroid injection. So, trained in a lot of different things. You typically, like you said, are going to be a diagnostician first. They're going to help you find out where is this pain coming from. Then they're going to hopefully come up with a multidisciplinary and a multidimensional treatment modality, looking at a variety of different options, whether it's interventional or non-interventional, and then provide those options for you, hopefully after they've diagnosed you, which means that they have to have a fundamental understanding of the different types of pain so they can put you in the right category and then figure out what are our next steps. Strong fund of knowledge is absolutely important, and then hopefully they're practicing with some integrity, and hopefully they're putting your outcome first and not their pocketbook first. Obviously, everyone needs to get paid, right? Everyone has to make a living, but they have to put the best thing forward, best options forward first. Now, here's the reality of pain management, and here's really why we are having a little bit of a problem with pain management in America. This is why it's costing America $635 billion a year, and why 116 million patients in America have some type of chronic pain. Number one, of all the pain doctors out there, all the people who are trying to help, the people who say, hey, listen, I'm a pain doctor, I really want to help you. Maybe they do. Maybe they all do. Let's just assume they all do. Over 90% of them have absolutely no accredited formal training in pain management, and that's a scary figure. Okay. Secondly, many of those pain doctors, many of those board certifications, there are board certifications out there that you could literally buy. Okay, so you don't have to spend a year, 2 years, 3 years, 4 years, 5 years training. You can literally buy them. You take a test, you pass, you call yourself board certified in pain management. And that's kind of sad. No other specialty that I know of in medicine allows that. In the past, interventional pain management had training programs that were incredibly variable. So let's say someone actually has done a program. They may not have been trained correctly. There's a big program right here in Chicago where they don't even learn how to do some of the advanced procedures that we have, which is kind of scary because you'll go and see them not knowing that this person has never even been trained in some of the advanced things that we do. There are many unaccredited programs. Literally, there are pain doctors who get their qualifications from someone's office. They go to someone's office to say, hey, listen, work for me for free, and I'll give you a certificate at the end saying you finished a fellowship. This happens actually more frequently than the accredited fellowships, which is really scary. How do you know that? You don't. Because they'll say, I am board certified and fellowship trained. And where was their fellowship? At some random doctor's office who probably isn't doing it correctly either. That's very scary. In addition, there are many trained and board-certified pain physicians who have variable pain practices. Why? Because the specialty wasn't even recognized until 2002. Medicare didn't even recognize it as a specialty in 2002. So all these training programs were just treating God knows what by people who were never even trained. So that's also another problem. So you wonder why we don't have a good definition of pain management or who a pain doctor is or why we see such variable quality. This is why we see that. And no other specialty in medicine has that variability. Interventional pain options, again, just sort of going over this real quickly. Different types of epidural steroid injections, facet and medial branch blocks, radiofrequency, joint blocks, nerve blocks, ganglion blocks, intrathecal pumps, spinal cord stimulators, percutaneous disc decompressions. Obviously, I haven't talked about ketamine infusions yet, and there's a reason for that. When do you go to a pain doctor? When do you go to a surgeon? Well, typically a surgical referral is someone for a patient, maybe they can't move, maybe something is broken, maybe they're losing function in their legs, maybe losing feeling, lack of bowel and bladder control, or maybe they've tried other pain management options and all of them have failed and their only option is surgery. When you have a pain management referral, well, a patient that experiences chronic pain. Quite frankly, I think the pain management referral should be first. Typically what happens is someone who has pain, maybe they'll go to the ER, maybe they'll go to a primary care doctor first, and then that primary care doctor will refer them to the surgeon, and then after everything has failed, then they go to the pain doctor a year, 2 years, 3 years later, when in some cases it's sometimes too late. What should happen is they should actually be going to a legitimate pain doctor first, getting the diagnosis first, and then doing the conservative options first. Recent trauma, for example, chronic pain in the neck, leg, back, CRPS, chronic problems that involve neuropathic pain conditions, RSD, fibromyalgia, whiplash injuries, failed back surgery syndrome, post-laminectomy syndrome. Those are all things that a pain management referral is appropriate for. So what is central sensitization? That is definitely something that should be referred to a pain expert first. Now, again, when I say pain expert, I don't even know what the definition of that is, because it's so hard to define that. But they should be seeing someone who's an expert in everything I've just outlined, okay? Central sensitization, as we discussed in the very beginning, increased responsiveness of nociceptive neurons to their normal input in the central nervous system and the spinal cord. The wind-up phenomenon refers to something that happens centrally. And what happens is those neurons stay upregulated. They continue to fire even though the traumatic event has stopped. They don't get the message. They don't get the memo that, hey, buddy, the injury stopped. You should stop hurting. They don't get that message, and it stays in that persistent feedback loop. Okay, so the nerves keep saying, "Hey, I'm hurting." The brain keeps saying, "Oh my God, we're having a traumatic injury. Let's start telling the extremity to stop." So it increases the sensitization, but the nerve's wound up, so the nerve keeps on sending those signals back, and keeps on sending more and more signals back, and it becomes hyper reactive. So you have central versus peripheral. You also have organic versus inorganic. Organic pain is real tissue damage. Inorganic pain is the central sensitization. So way back in 1644, Descartes actually described this phenomenon. So 500 years ago. I mean, it's amazing that we still don't understand it. But he actually said, hey, listen, someone gets stubbed in their toe and their brain reacts to it. Their spinal cord and brain reacts to it. Well, now we actually have data to help support that. What you can see here, and I'm not going to go into every detail that we see on this image here, simply because the Oscar judges over there have already put up their time card. So, yeah, but I'm gonna go over like every other celebrity and diva does. Okay, so I hope you don't mind. I did start late. But so what I will do though is I won't go over every little detail here, but there are a lot of details here. But what is happening is there's something critical that everyone needs to understand. It's called brain reorganization, okay, or cortical reorganization. That is what's fundamentally happening with every injury. With every type of pain, there's cortical or brain reorganization. Now, to put that into fancy little, or non-fancy terms, it means that your brain remembers things. There are memories forming, right? Every experience you have, even this one, hopefully this is not painful, but if it is, you're forming a memory. Gee, that was painful, I'll never go to a lecture again. You're forming memories. And based on those memories, also called experiences, it shapes who you are as a person. This is why it's so fundamentally important to understand who that person is. Because you're going to be averse to certain things, you're going to like certain things, and that happens no matter what you're doing. It doesn't even have to be a painful condition. Every experience, there's cortical reorganization, which shapes who you are as a human being. Typically, central sensitization is most mediated by something called the NMDA receptor. And some of you have probably heard of the NMDA receptor. That lives in all the central tissues, brain, spinal cord. When the NMDA receptors are hyperstimulated, that's when we start seeing the wind-up phenomenon in the central sensitization. And ketamine, by the way, works on the NMDA receptors, but it does so much more than that. It works on about 10 different pathways. I'll quickly talk about that. So again, central sensitization goes way beyond, though, just looking at the NMDA receptors. It has to deal with what I just said before, memories. Okay, pain is an experiential process. And the memories that are formed when someone has an injury, unfortunately in some patients, causes a reactive process that we can see on functional MRIs, and we can see with different objective tests, and we can actually physically see the brain reorganizing itself. So what are we trying to do then, ultimately, is to reorganize those pathways. So the NMDA receptor plays a role. Gene alteration is affected when central sensitization occurs, and that occurs in the dorsal root ganglion. Decreased inhibition occurs, microglial activation occurs, and then finally thalamic and somatosensory cortex changes occur. So again, a lot of changes in the spinal cord, a lot of changes in the brain. What are the different types of central sensitization? This is just a partial list. Anxiety, chronic pain in general, okay, any type of chronic pain can lead to central sensitization. CRPS, RSD, depression, fibromyalgia, headaches, opiate-induced hyperalgesia. Opiate-induced hyperalgesia is when you become more sensitized to pain when you take opiate medications. So people taking opiate medications for their pain, not realizing that some of those opiates are actually causing more sensitization. Horrible feedback loop. And by the way, that doesn't include things like dependence and tolerance. Those are completely separate issues. Phantom limb pain and PTSD. Again, more neurophysiology of the central nervous system and central sensitization. We won't get into all of these, again, because of time, but I do want to point out this is the pathway of what happens. So you have a nociceptive transmission. Typically, you'll have a pain signal. It'll get processed. It'll go to the brain. You'll handle it appropriately. Done. But what happens when that doesn't happen? You start seeing acute sensitization both peripherally and centrally, where those gates stay open. The wind-up starts. It just keeps saying more and more pain, more and more pain. Then you have late central desensitization, where this, as you can see, becomes just this horrible sort of feedback loop that just doesn't stop. And then finally, you see disinhibition. You see complete disinhibition, which is essentially nothing's really communicating with anything anymore. You're just having pain, and sometimes just random pain in different areas, because everything's disinhibited. Things don't make sense here. Everything's short-circuited. That's the best way of putting it. So we won't go over all this either for interest of time, but what I do want to point out, these are functional MRI images pointing out different stages of chronic pain, different stages of central sensitization. And you can see, how a lot of these images don't look the same, and there's a reason for that. Those images are representing different types of chronic pain and central sensitization. This next one actually breaks it down into what we see. So, for example, with low back pain, we'll see central sensitization. Again, central sensitization is what happens when the brain becomes hyperreactive to a problem. So if you have low back pain that hasn't been treated well, you're going to slowly become more and more sensitized to that. Why? Because the brain's trying to protect your lower back. It's going to say, hey, buddy, stop injuring your lower back. Let me make it a little more sensitive, just to remind you that we don't want you to, do squats with 200 pounds or something. So lower back pain, you'll start seeing this increased, activity or even decreased activity. It depends on which area of the brain we're looking at. And each condition, this is what's really interesting, each condition is kind of like a fingerprint. Each condition has very specific images. So there's something called brain mapping that we can do, where we can literally identify what condition that patient might be predisposed to based on these kind of images. Osteoarthritis, different than lower back pain. Post-herpetic neuralgia, as you can see, different than lower back pain, different than osteoarthritis. And pelvic pain, again, different in its own way. CRPS, if we use that as a model of central sensitization, we can actually see some very significant changes on functional MRI. This is a healthy subject, healthy meaning someone who doesn't suffer from CRPS, and then you have a patient who has CRPS, and look at the differences in hyperstimulation as well as hypostimulation. And again, these are kind of fingerprinted. You could take many CRPS patients and do functional MRI imaging, and you'll see very similar fingerprinting, very similar areas of hyper and hyposensitization. We have a look at a time scale. We look at brain reorganization. We can see, look at this image. You don't need an MD to tell me that this does not look like this, does not look like this, right? Right? Well, you don't need an MD to do that, but why in the world is it that MDs don't know this? I don't know. I'm going to show you. I want to get to the last slide because I'm going to show you a comment that an MD made about central sensitization. That MD thinks that all these images look the same. So just keep that in mind, okay? Keep this slide in mind and then the last slide. We published an article in 2008. We're actually first to describe this connection between the stellate ganglion and central sensitization. We actually showed that when you inject the stellate ganglion way in the neck here, why in the world would injecting something in the neck affect the brain? Well, it's because there's a direct connection between the stellate ganglion and nerves that are in the amygdala, the hypothalamus, and the insular cortex. And what we did is we sort of reset those neural inputs and sort of, again, stop that hyperalgesia, that hypersensitive process going on. So when you can describe the mechanism of action, again, it doesn't matter what words you use, science is supreme. So what are other treatments for central sensitization and CRPS? Physical therapy, mirror box, graded motor imagery, tactile discrimination training, sensory discrimination training, neuropsych, EEG biofeedback, also called brain mapping, cognitive behavioral therapy, relaxation techniques, and hypnosis. When we look at medication treatments, we have alpha and beta adrenergic compounds. We have anti-inflammatories, bisphosphonates to help with bone density, Botox, calcium-regulating drugs, GABA analogs, ketamine, local anesthetics, opiates, SNRIs, and vasodilators. Treatments that are interventional for CRPS and central sensitization include epidural blockade, intravenous immunoglobulin, intravenous regional sympathetic blockade, ketamine infusions, selective sympathetic nerve blocks, and spinal cord stimulators. I want to briefly talk about ketamine. Okay, ketamine is this drug that's been around for, 54 years. 54 years. And yet, so many people don't know about it. You go to most physicians, they'll say, I don't know about it. You ask most ER doctors, they'll think that you just want to get high or something. It's amazing. 54 years have gone by, and this has been on the market for about 46 years. This is not a new drug. In fact, it's so not a new drug, and its uniqueness is so profound that the World Health Organization has listed it as one of their core medications What core medication is it's the minimum that you need, the minimum medical requirement that you need to have any type of basic healthcare system. And yet we don't know much about it as a society or even in the medical world, and its utilization is pretty sparse. It's highly lipophilic. It is racemic. That means there's an S and an R. Onset's very quick. Duration's relatively short. It's metabolized in the liver, and it's excreted via the kidneys. There's different structures. There's the R structure, the S structure, and the S plus structure. What does that mean to you guys? Not much really, but it does mean something that for us, it means that the S enantiomer, okay, this particular structure has about 3 to 4 times greater affinity for the NMDA receptor. So in a perfect world, we would just use the S enantiomer. Typically, we have mixtures that contain both. And so that's where getting brand name ketamine versus non-brand name ketamine actually makes a huge difference, because a non-brand name typically has mixtures that are less favorable or cheaper or not manufactured as well, and that can really affect our ketamine infusions and why some patients have some really bad experiences as opposed to others where, you know, brand name and higher quality products were used. The NMDA receptor, we talked about it briefly, but that is the receptor that we found has been implicated, one of the main receptors in central sensitization. Ketamine acts as a competitive antagonist for the NMDA receptor. So again, by binding to that receptor, what it's doing, it's freeing that receptor up from the constant and persistent attachment that it's had, which has caused that wind-up phenomenon. So again, it's like resetting that receptor. The NMDA receptor is present in all CNS nerves, so in the spinal cord and the brain. It's highly permeable to sodium and calcium. It's also permeable to potassium, and magnesium binds to the NMDA receptor. This is why magnesium has been used for central sensitization in CRPS, because it can act as an NMDA antagonist. NMDA signaling is very important. You don't want to get rid of NMDA signaling because that is what causes normal gene expression and normal neuroplasticity. So, you know, some patients are on ketamine orally or nasally every single day. I don't believe in that, and this is actually one of the reasons why, because you can actually cause damage to your nerves if NMDA is not normally expressed. You will see nerve degradation if normal NMDA activity does not occur. However, if too much NMDA activity occurs, you'll also see the same pathway. You'll see, you know, bad things happening. Again, central sensitization, CRPS, fibromyalgia are examples of what will happen. So this is what the NMDA receptor looks like. Again, I won't spend too much time on this, but you'll see it's actually a very complex receptor, and there are multiple subreceptors that it has. So multiple things can bind to it in different areas, causing a different effect. Okay, I won't get into this too much. Mechanism of action, as you can see on this slide, I won't get into this, but I just want to point out, look at this, there's a lot of different receptor sites. There's the GLU-N1, GLU-N2A, N2B, N2C, N2D, NR1, NR2AD are just some of the subreceptors that are on the NMDA receptor. This is important because next time, if you ever discuss this molecule of central sensitization with anyone, to understand the complexity of what we're looking at here is so important. Other subtypes and other places that ketamine can show its expression include things like CFOS, which is a gene expression site. Okay, so gene expression. So when you're binding to something where you see abnormal gene expression, you want to reverse that. So binding to CFOS, Jun D, B, and FOSB will allow you to slow down this abnormal gene expression, which is what's occurring, which is why it's so hard to break it with a simple old pill or a simple old injection, because that won't stop what is happening here, which is a hyperproliferation of all of these subreceptors. Again, more mechanism of action, NMDA receptors, you have CGMP, AMPA, mGlu-R, a lot of different receptors, dopamine, adrenergic. Also, ketamine also makes you more sensitive to mu-opiate receptors. So what does that mean? That means that ketamine can actually reset some of those mu receptors, getting rid of that opiate-induced hyperalgesia. So that's important. So now, we've actually used ketamine infusions For patients who are on excessive amounts of opiates, resetting their perception or their need, the central receptors to opiates, thus literally overnight going down hundreds of milligrams of morphine equivalents because they don't need it anymore. Their brain doesn't need it anymore. Their receptors don't need it. Again, it's like resetting those receptors. And how does that happening? It's not voodoo. It's all because of the basic understanding of the mechanisms of action that are occurring. So let's skip over this. Just again, more mechanisms of action. More mechanisms of action. I'll skip over this just for time. Obviously, I'm more than happy to answer those questions afterwards. More mechanisms of action. What I want you to get out of this is the mechanisms of action are so large and so profound that it's more than just, I'm just binding to a simple receptor. So this kind of summarizes the mechanisms of action. You have multiple channel effects, NMDA, HC1N, acetylcholine, L-type calcium, glutamate, glycine as well, noradrenaline, dopamine, et cetera, et cetera. And by affecting those receptors, by upregulation or downregulation is how we can change central sensitization. You know, the brain's an incredibly complex organ, and not understanding the complexities is where I think we fail in the medical world. But understanding the complexities and understanding how you can attack each of those, kind of like, you see in the military, you don't just send like one airplane, you send multiple airplanes, multiple soldiers, land, air, sea, whatever, to gain an advantage on your enemy. And it's the same thing here. If we're going to attack the brain and try to reset it, we want to make sure that we attack all of those pathologic receptors at the same time. And that's the only way that we're going to be able to sort of at least win the battle. So what are the effects of ketamine? Actually pretty interesting. Besides all this other stuff we talked about, ketamine is one of the only sort of pain medications that we have that actually is not an inhibitor of breathing. So that's kind of nice. So it doesn't inhibit breathing. It also increases the, it is kind of nice. It's kind of nice. It's kind of nice when people breathe. It increases the cardiac output, so it increases blood pressure, increases our heart rate. That's kind of nice because it actually increases perfusion, So we actually want more blood flow. It increases perfusion. It doesn't decrease breathing. It does all of those things that we just kind of skimmed over, and it increases cerebral blood flow. That's a major problem that we see sometimes, is there's just basic lack of blood flow. We see that with headaches sometimes. Headaches is sort of the same thing. You get the basic lack of blood flow and people get really bad headaches. There's also some evidence, actually a lot of evidence, that ketamine perioperatively reduces chronic pain and reduces requirements for opiate medications. Why is that? Because it, again, prevents the progression of hypersensitization, both peripherally and centrally. There are many studies that have been shown to do that. I just listed a few of them here. So we may wonder, why isn't ketamine used more often perioperatively? Well, there's a few reasons we'll talk about at the end, but some of them, in the best terms, it's because of laziness, and the worst terms is because of simple ignorance and bad behavior. So again, reduce acute pain, reduce chronic pain, reduce peripheral sensitization, reduce central sensitization, and reduced opiate-induced hyperalgesia when ketamine is used perioperatively because it's working on so many different mechanisms. Ketamine and PTSD. There are many studies to show this. We have a lot of experience with this as well, with ketamine infusions reversing PTSD. What is PTSD? PTSD is just like anything else. It's a horrible, horrible experience that leads to long-term disability. The injury has stopped, but people are still disabled. Why is that? Because the brain has become so sensitized to that experience that it now perceives non-traumatic things as traumatic. That's why a soldier will come back, they'll close the door, and they'll think a bomb's going off because they become so sensitized to that. But it interferes with all of their basic functions in life. And we've actually seen, personally, we've seen this, but also with studies, we've seen that the memories won't go away, but that hypersensitivity will go away, so they can become more functional literally right after the infusion. Literally, they'll come in, freaking out, they'll leave like they were before their injury. Perfectly fine, no anxiety, no PTSD. And why is that? It's because of the ketamine infusions. Ketamine infusions is a long-duration infusion of a drug called ketamine, which we kind of briefly talked about, where we can reset some of those receptors that cause central sensitization and all those diseases under that, when done properly. And by properly, I mean it's not just doing it, It's monitoring the patient, finding what the correct dosing is for that patient in a completely controlled setting. We do it in a surgery center, not in a closet like some other physicians do. And you have to use the right adjuncts. It is essentially an OR case without actual surgery. So you treat it like a regular anesthesiologist would, where you look at the patient for who they are, and you try to assess the patient for what they need. And when a ketamine infusion is done properly, you're able to see, and when you get the right dosing and the right sweet spot for that patient, you're able to see a complete resetting of so many different receptors and so many different pathologic processes that the patient's central sensitization goes down as sometimes to zero, and they become literally pre-injury state. So pretty cool stuff. So challenges, last slide, I promise, last slide. Challenges to treatment. Why, now that we've kind of briefly looked at what central sensitization is, we've looked at ketamine, we've looked at how complex it is and what can happen, why don't more people do it? Well, number one, lack of education, okay? Right now, whatever brief stuff you've been exposed to, you actually know more, or at least been exposed to more than most physicians in America have to both ketamine infusions, and central sensitization. Physician stereotypes, quite frankly, there's still a lot of physicians who thinks pain patients are some, infectious disease. It's like, you got a bunch of Zika patients or something, and it's like, stay away from me. You probably go in there, putting masks on. Oh, I don't want your chronic pain. It's really, it's really bad. It's really bad. A lot of stereotypes against pain patients, and most of it has to do with egos. If they don't understand something, instead of asking, gee, what's going on? Let me help you. Please educate me. They become aggressive, right? Kind of like the guy who's asking for directions, and he's lost. He won't stop. He won't ask for directions. He become hostile to his passengers and say, I know what I'm doing. I've been driving for 20 years. It's like, well, buddy, you've been driving wrong for 20 years. But nobody ever brings that up. Physician laziness. Some physicians are just, quite frankly, they're lazy. They really don't want to learn. They just want to go home, clock in, clock out, get their paycheck. Facility logistical issues. It took us a couple years to get the surgery center up and going so we could actually do ketamine infusions. A lot of other physicians haven't invested that much time or money into doing that, so they literally will just shove someone in a closet, give them a bunch of ketamine, and call it a ketamine infusion, and that's totally not what it is. Complexity of the science, it kind of just skimmed over some of these slides, but I think you can at least appreciate that this is not simple science. There's a lot going on here. And they don't have the time, energy, or sometimes even the mental capacity to understand that, and that's a problem. Complexity of the treatment. It's not just giving a medication. It's doing a well-balanced procedure. Lack of coverage. Now, after all this, that might end up being the biggest one. There's a lot of insurance companies that don't pay for it, and it takes a lot of time, a lot of labor, a lot of people to do it. There's very few insurance companies that cover it, and the ones they do that really don't pay that well. And that's where we get the final one, minimal reimbursement. Those are the biggest challenges, quite frankly. It's very hard to do something that where you lose money or something like that. So those are some of the biggest things. I have this slide up here. I just want to read it to you. This is a physician, okay, an anesthesia interventional pain doc in the Chicago area who happens to be the head of a fellowship training program, okay? So that means he actually is the one teaching future interventional pain doctors what to do. And this guy was supposed to do an independent medical examination on a work comp patient who has CRPS. Not only CRPS that's diagnosed by me, but CRPS is diagnosed by, I believe, about 7 other physicians, including her 3 other pain doctors, 2 other surgeons, and like a primary care doctor, okay? So like everybody knows that this lady has CRPS. And complete resolution of CRPS symptoms with ketamine infusion. So you kind of proved it with the ketamine infusion. You know what I mean? Like if she didn't have CRPS, she didn't have central sensitization, ketamine infusion wouldn't have helped her. Complete 100% relief. So this is what this guy had to say, because this guy was basically paid by attorney to say that she has nothing wrong with her and this case should be dismissed. So, been there, right? Who said that? Yes. Yeah. No, listen, everyone has, and that's why I bring this case up. It sort of brings, why are we even talking about this? It brings it home. This is why. Because this piece of work, I'm sure his parents are so proud of him. He said, well, they might be. I mean, he's making a lot of money, He's making a lot more than I am. He moved into a $3 million house, so he's making a lot of money. Anyway, in the USA, there's it's like 12,000 square feet, too. It's a massive house. I looked it up on Zillow. It's nuts. Anyway, neither here nor there. He might be listening. I don't know. But I didn't say his name, so that's good. In the USA, there is some following, even absent FDA approval for the use of ketamine infusions, which is, by the way, not true. Ketamine is absolutely an FDA-approved drug. If you saw 1970, hey, I don't know, maybe he was sleeping the last 46 years, but anyway. In documented CRPS criteria meeting cases, Miss, I blanked it out, did not meet diagnostic criteria for CRPS, and therefore the use of ketamine infusions was not indicated. So it's kind of interesting. First he says it's not approved, then he says, oh, well, I guess you could have used it for CRPS, but she doesn't have CRPS. He kind of contradicted himself. Anyway, she also does not have, quote, unquote, central sensitization, purely speculative diagnosis. Did I not just spend some time talking to you about central sensitization? Did I not just spend some time showing you some pretty intense functional MRI pictures and show you so much information that I skipped over because there's too much information? And this guy says that all of that crap is speculative. It doesn't even exist. It was all made up. She does not have, quote-unquote, central sensitization, purely speculative, nor does she have peripheral neuropathy. All the EMGs are normal. She is therefore not a candidate for ketamine infusion. So basically, this is the challenge we see. Okay, this guy now, what has happened to this lady? They said you're at maximum medical improvement. We're not going to pay for anything based on this, sort of pay-for-play report. Anyway, with that positive note, any questions? Speaker panel? Okay, perfect. All right, great. Thank you so much. Sorry I went overboard. Appreciate it.